我哋今日第一個環節嘅講師係楊世模博士。楊博士 Simon 係現任香港田徑總會首席副主席，同中國香港運動禁藥管制機構有限公司嘅名譽師傅。佢喺以往多屆嘅奧運同埋亞運等等，為港隊擔任首席物理治療師。楊博士亦都係一位長跑嘅跑手，對馬拉松嘅訓練同埋比賽都相當之有經驗。事不宜遲，而家將時間交俾楊博士同我哋分享 Rehabilitation of Muscle Injuries， 有請。
I think I better stand rather than sit. Even though my back is not too good, but I always feel I feel a bit more superior when I stand and you sit. I was told that there are students from various institutes. Can I know who are the students from PolyU? I was told there are some students from PolyU. So as usual, the PolyU student always sitting at the back. And student from Donghua College, you see, the student from Donghua College is a bit different. I'm not too sure whether you know I'm one of the council member of Donghua College. And then there are students from other institutes. Any student from Metropolitan University? Oh, good on you. Nice meeting you all. Which years you are in? Year 1, year 2, year 3? Year 4, oh, going to graduate. So you have to making sure that you get, your course get registered. So otherwise you can't practice. That's very important, isn't it? And then any student from St. Francis University? St. Francis University? Oh no, because they become university now, and that's why they won't bother to come, isn't it? So if there's a Caritas Institute, will be much difference. Okay. Anyway, I also know there are students from other institutes because I'm a physio, so I'm mainly sort of trying to locate. The physio student. I also understand there are colleagues from various NSA. Thanks for coming for this particular seminars related to rehabilitations. And the reason why I'm the first one to present is very often students are coming late, and they normally arrange the speaker who are relatively less important to be the first speaker, such that when all the participants come in, the more important speaker will have their turn. So my one will be relatively simple. I was tasked to give a talk on rehabilitations of muscle injuries. That should be, I think, for most of the physio students, should be simple and straightforward, isn't it? So what I intended to do, not welcome. Oh, that's better. Okay, this is the overall content, and within this 30-odd minutes. So what I intended to do is, I think the first two you should all know very well, isn't it? The classification of muscle injuries and management principles. So we'll be very brief. If I can, I will try to discuss a bit more controversial area in here, namely in particular in the acute management of the muscle injuries. And then the second part, I will use hamstring injury as an example. How we deal with muscle injuries in the contention of prevention, risk identification, and rehabilitation. So that will be the contents of my talk. Okay, first one. I think you all should know, isn't it? As a year 4 student or whatever who studies musculoskeletal systems, you know very well this is our traditional classification of muscle injuries, isn't it? Grade 1, grade 2, grade 3. I don't think we need to discuss in here. I think that is what possibly you learn in your textbook, isn't it? So is there any other classification of muscle injury that you have learned other than that? Any other classification that you have learned? from your lecturers or whatever? I think the student from PolyU may have learned, isn't it? I don't know. If you, I gave a lecture last year on the soft tissue injury. I think I have briefly mentioned that. We know that now, in terms of the classifications of muscles injury, there are another classification, just in case people giving you a sort of a classification like this, you should know reasonably well on this. I think one of the reasons why we're using this classification is because the MRI has become more common, more easily accessible. And that's why instead of doing your clinical examination, classify into grade 1, grade 2, grade 3, by using the MRI, we can easily classify the exact area and the severity of the injuries. So this is a new classification of muscle injury defined by 4 grades, and in terms of the site in ABC, is namely the site at myofascia, muscular-tendinous junction, and the intratendinous area. So if you're not too sure, I give you a slide, pictures to have a look onto this. So these are basically the classification that the BA system used. First of all, it's the site that you should know. If the injury is at the myofascia, this is A. If the injuries from the MRI is the muscular and muscular-tendinous area, that will be B. And then in intratendinous will be C. And then, of course, you should know that in terms of the rehabilitation, if you are intratendinous, it's very likely it will take a longer time rather than it's a myofascia or muscular area, mainly because it's relative sort of a poor vascularization in that area. So that's the site. And then in terms of the severity, we are talking about grade 0 to grade 4. I'll quickly go through that. So it's an OA, there's a within normal MRI. OB is a generalized muscle soreness with normal MRI or MRI characteristic. Basically, it's a kind of DOMS or whatever. So clinically, it's nothing serious. So grade 1 is our traditional classification, isn't it? So grade 1 is basically clinically you expect through range of motion within 24 hours if you're doing your clinical examination. From your MRI, this is what you expect. So low greater than 10% into the muscles, and the longitudinal length of less than 5 cm within the muscles, if this is sort of grade 1. Grade 1B is within the muscles or more commonly at the muscular-tendinous junctions. And the limited area of less than 5 cm and less than 10% of the muscle cross-sectional area is grade 1B. Of course, if having this into your mind, for grade 2, grade 3, grade 4 is a sort of a kind of increase in severity. So for grade 2, clinically, you expect you're not able, the range of motion of the affected limb at 24 hours will usually show some limitation and with pain. I mean, clinically. There's still not full range of movement post day 1. That could be grade 2. And then in terms of from MRI finding, then for the signal changes, we'll measure between 10% to 50% of cross-sectional area, and the site of the injury will be extended between 5 to 15 cm. And then 2B basically will be, instead of at the fascia, will become muscular-tendinous junctions, and 2C will extend it into the tendon, and so on and so forth. So that's the grade 2. And for grade 3, that basically, clinically, is extensive tears to the muscles. So for that, your patient will usually present with sudden onset of pain. Sudden onset of pain. That basically, during the sports activities, he can't finish, can't complete. And may fall to the ground. I'll show you an example later. I'll show you a video, you can see that very well. And the range of movement at 24 hours is significantly reduced with pain and swelling, and pain in walking, and so on and so forth. MRI finding, grade 3A and grade 3A is myofascia. 3B is muscular and muscular-tendinous area. And that from MRI finding, you'll notice that 50% of muscle cross-sectional area and greater than 50 cm in length. And 3C, instead of the myofascia, 3A, 3B, musculotendicular area is the intratendinous area. So otherwise, that will be the same. So there's a grade 3. So grade 4, simple, complete tear, isn't it? So for grade 4 will be complete tears, base, so on and so forth. So I tend to be quick enough such that I can finish my other part of the lectures. Just in case you're not too sure, refer back to the original articles and have a good look onto this. So next time, when the doctor presents to you that your patient or your athletes have a grade 3B tears, at least you know what is he talking about, isn't it? I hope that is the message that I can get through to my fellow student onto this. Okay, PT management or general management of muscle tears. Muscle tears or muscle strain injury, whatever you want to call it. First, very important, you need to adhere and respect the tissue healing timetable. That you should know. Overlap with each other, inflammatory phase, proliferative phase, and remodeling phase, so on and so forth. You must respect that. Just like in the last Asian Games, I noticed one of the very respectable physio who a patient having a very acute sprained ankle, and then I think it's better to say he or she perform a strengthening exercise to the patient. So I suppose there's not respect to the healing frame of the soft tissue injury, isn't it? So you have to respect on that. If not too sure, go back to your textbook. Time will not allow me to elaborate on this. And immediate treatment following that you do, what are you doing? Price, police, peace, love. So you learn about this? You acute management. So what will you go for? You go for price. You know price, isn't it? You should know price. You go for police. You know what is police? How many know who is police? You go for peace. After the police, we want to have a peaceful world, isn't it? Peace? No peace? How about love? We love each other. Our society needs this, isn't it? So you know all this? Okay, don't worry. If you don't know, then we discuss a bit more on this. This is acute management. And then in the reparative phase, we improve the range of motion and so on and so forth. And then remodeling phase, normalization of range, strengthening of the tissue, so on and so forth. Let's have a look onto I think this is part I'm a bit more interested to talk about. Okay, I think in my sort of, when I receiving my educations, then at that time, when talking about the acute management of acute injuries, we talk about RICE, R-I-C-E, rest, ice compression and elevation. I received my education in the very early 80s, late 70s. And then people talk about price. We add protection. You have to protect the part, isn't it? You rest the part, and then you ice it, compress it, you elevate it. You should all know the principle behind. And then later on, we talk about police. The difference between police and price is that you replace rest, R, with OL. OL. You know what's OL? If you don't, at least you know what is KOL, isn't it? From your Facebook or from whatever. OL means what? Optimum loading. So that means now, instead of you complete resting the part in your acute phase, you're talking about optimum loading, appropriate loading onto the injured part. Because we know very well, in the matrix synthesis, in the molecular response, that we respond to mechanical stimulation. You learn about the terms mechanotransduction, which is very much different from biomechanical signals. You're taking the medication, the effect is through the biomechanical signals. If you're using your physiotherapy approach, your mechanisms is using your mechanical stimulation through the mechanotherapy. mechanotherapy. Not sure, you ask Professor Google or Dr. YouTube. They should tell you more on this, or you go for your GPT or whatever. Okay, and what is peace and love then? I elaborate a bit more in here, such that you should know. This is the peace and love sort of suggested by this group of investigators. Namely, you look into here. The P stands for protection, elevation, no anti-inflammatory tablet, compression, and education. This is the first part, and then followed by optimum loading, stay optimism, revascularization, and exercise. So that's the part. So the only difference that you can spot out from here versus price and police is what? Without the ice. Very important. Without the ice, then we have no money, isn't it? Your patient coming to see you in the acute phase in OPT, you give them ice, isn't it? So no ice, no consultation. That could be a problem, isn't it? So we have to defend ourselves whether ice is important or not. If ice is not important, then you probably patient doesn't need to see you in the very acute stage. Then all your crowd will go back to the storeroom, isn't it? You know, SI, they spend a lot of money buying all these things. So how many of you still think ice is important? And, so that means most of you think ice is no more important. So why ice is important then? For what? Control swelling, isn't it? Vasoconstrictions, isn't it? Stop the bleeding, isn't it? If you ask me, I think it's totally wrong, the whole concept. I think at least, but I'm old enough to be wrong most of the time. I think if you talk about acute soft tissue injury, I mean traumatic soft injuries, if the swelling is always there, unless you put it this way, unless you put the ice and compression immediately after the injury, right on the spot, you might be able to control the exudate to coming out. So otherwise, there's rupture of the blood vessels. There's exudate coming out. And then the blood will clot very, very quick. So your whole idea is how to enhance the swelling, to be frank. It's how to enhance the swelling. To enhance the swelling is through venous return. Through the venous return is by elevation and your muscular pumping action. And your muscular pumping action. That's the best way to enhance resolve your swelling. And the ice is basically sedative effect. You have the ice reduce the pain such that your patient can start some muscular pumping action, and that can enhance the swelling. It's not the ice helping you to do vasoconstriction. It's not the ice that helps you to reduce the swelling. That's not the case. That's not the case. Still though, we still need to defend why ice is important and why they said ice is not important. So that's the paper called ice is not important is based on the rationale like this. The rationale for excluding the ice is they said even mostly analgesic, ice could potentially disrupt inflammation. We must respect inflammation. And then for that, you will not able to have a good enough angiogenesis. That means revascularization. That means building on new blood vessels. And delay the neutrophil and macrophage infiltration, white blood cell. For the white blood cell, as well as increase in immature myofibers. And for that may lead to impaired tissue repair and redundant collagen synthesis. So that is why they sort of have a statement like this. The statement like this is based on one or two animal studies. And I will show you the animal study that they quote. And then, of course, there are no high evidence on the efficacy of ice for the treating of soft tissue injury. So because this is important, if that's really sort of stopping the new blood vessels, revascularization, and causing immature myofibers, then perhaps ice could be contraindicated in the very acute stage. Now that's the paper that they quote. People know me good enough is I always look into original papers. Something that I hope students can learn in here. don't quote paper that you're not too sure. Always look into the original paper yourself. I saw too many articles, and especially in the introduction. Close many papers, they are wrong, keeping wrong. Not until you read the original paper, something that perhaps you can learn. Now, that's the original paper that they quote. It's studies. It's the animal studies, effects of topical ice on inflammation, angiogenesis, published in Frontier in Physiology, recently, 2017. So what they say is ice attenuate or delay the inflammation of inflammatory cell. Oh, no good, isn't it? And then the expression of pro-angiogenic factors and change in vessel volume in muscle following injury. So that means no good. However, this effect were not sufficient to reduce capillary density or prevent effective muscle regeneration. So yes or no? But when I sort of highlight in here, we apply eye treatment at only one point soon after muscle injury. That means this animal studies only apply ice for one session and then sacrifice the rat. For you, how often you apply the ice? Every 2 hours, every 4 hours, isn't it? So we never know. So that's what they do. Active rest divided into 2 groups. So this is the icing, this is the same. And then in different time period to sacrifice it and have a result like this. So it's up to you to sort of how could you buy these particular studies? Because only one times application. Direct application of ice onto the rat will very much difference onto your human being. The rat will never complain to you whether the ice is too cold or not. For the human being, you really want to, I suppose you want to get this effect, the temperature, the tissue temperature must be very, very low. With the tissue temperature getting that low, I suppose the patient, your athletes will already telling you that it's too cold, that he needs to stop, isn't it? So something that you need sort of, you need to understand before you apply your peace and love, or you still want to go for your police, or you want to go for your prize. And that, I leave that for you to decide, or let that for you to ask your university professor. If not, you can ask Professor Google again, or Dr. YouTube. Okay, so that is the first part. And this is, well, in fact, when you're talking about the peace and love, the story is not end. One of the sort of a more recent study in 2021, it says minor soft tissue injury may need peace in an acute phase, but moderate severe injury require care. So all this sort of short form is playing around, and in fact, we're telling about you that for this, they're still cutting on to use the cryotherapy for most of the injuries. Okay, so that is for the very acute stage. For other stage of management, for in your proliferative phase or remodeling phase, it's a general principles that you should all know, isn't it? From isotonic to isometric to isotonic, and then concentric to eccentric, low resistance, high resistance, blah, 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 so on and so forth. And then from endurance to power and neuromuscular control, you should all know reasonably well under this. So for that, I think I better get on into the next part. Is the injury itself. As I said, I will use hamstring injury as an example to telling you risk factor identification, prevention, and rehabilitations. So how many of you have suffered hamstring injury before? None of you. That means none of you are a sprinter, high-speed athlete, or none of you participate in exercise activities. Okay. Now this is this is a very long. This kind of injury, hamstring injuries, very, very long. I think this is one of my project when I'm doing my physio school, looking into the muscle injuries, hamstring injuries. If you look in this one, this is a hamstring injury. Len Carford, Hasty Carford, in 1976 Montreal Olympic Games. Yes. Okay. Have a look on if you're not sure, I show you a video. Have a look on this. Have a look onto this. Look at this. This lane. It's a 4x1 in the Incheon Asian Games. This and this. This is second leg. So have a look onto this one. Pass. Ooh, can you see? I can't pass. So it's a vacuum pull hamstring, very severe pull hamstring, and the athletes cannot pass the baton, but they never give up, take the baton back, and finish at the last one in the heat. This is a 4x1 100-meter heat in the Incheon Asian Games. So there's only, but luckily enough, there's only 9 teams. They came last. They should not able to get into the final, isn't it? But somehow, one team has been disqualified because of the appeal or whatever. So they can get into the final. And then you couldn't believe. In the final, of course, they replace the injured athlete. They get a bronze medal. They get a bronze medal in 4x100 meters. So that is the pull hamstring that you can observe. And that is the sort of, you can look at his facial expression. He really can't pass the button and then fall down, so in full agony. He can't walk, and then have to take him sort of back off the field from the stretchers and then sent to the hospital. So that will be at least grade 3, isn't it? At least will be grade 3. So that is what you notice is, well, when we're talking this, is very often when the injury like this is high speed, isn't it? It's when you're doing in your swing phase. If you notice in your swing phase, when your quadricep is trying to extend, when you're trying to extend towards the end phase, your hamstring have to work eccentrically, isn't it? To arrest the swing, isn't it? Such that he can do the landing phase. So because of this, people always think that is a muscle imbalance between the quad and the hamstring, isn't it? This is too strong concentrically, and that's too weak eccentrically. That could cause the problem, isn't it? Okay, this is the sort of a common sort of a scenario we observe for a sprinter, and that's the case. You can see in here, throughout all the musculotendicular junctions in here. So it's a very, very poor grade 3D injuries in here. Okay, so for this, then let's have a look onto the hamstring sort of causative factors of hamstring then. Hamstring injuries, as I said, sort of the first possible problem is the muscle imbalance, isn't it? Muscle imbalance, as I can say, that at least you notice that the balance between this muscle and this muscle, quad and the hamstring. So muscle imbalance, then you have to look into what do we mean by muscle imbalance? Is it muscle imbalance at the pittock? Muscle imbalance at concentric versus eccentric? Or concentric versus concentric? Eccentric versus eccentric? Even though it's concentric versus eccentric, at what speed? At what range? There's a whole lot of sort of a possibility that you need to consider, isn't it? If you consider the injury, like this, it's very likely it's a concentric versus eccentric towards the end range, isn't it? At high speed. Now, but I don't know. We have to look into the evidence later on. So there are muscle injuries. The hamstring will be muscles. And then people will say that it could be the fatigue. That could be the fatigue. Then you need to, if this is the fatigue, then you need to notice that if this is the fatigue, then it's very likely, or rather likely, the injuries will add towards the end of the event, isn't it? When the fatigue is taking place. That perhaps you can consider. Flexibility. So how important is the flexibility in this case? Is the muscle injured at the end range in which the flexibility is important that you need to consider. and the new motor control, and the core stability. These are all the sort of possible risk factor that has been suggested in the literatures. So for that, we have been doing some kind of literature search some years ago. You know very well, I have retired from the university for quite a number of years. That is one of our earliest studies looking into the screening tools for effective prediction of hamstring injury, a meta-analysis. So basically, as the literature review, that what we search, and then what we find is 25 prospective studies in which there are 9 is soccer, 9 of them is Australian football. For athletics, it's only 4 studies. And then we have roughly American football, in total about 8,000 participants. So that is one of our studies to look into the possible screening tools for prediction of hamstring injury. So this is the factors that they have investigated, or risk factors. The muscles, many studies look into the muscles. From that, they do the screening tool include isometric, isokinetic, so on and so forth. Flexibility, new motor control, fatigue, or combination of muscle flexibility, muscle and new motor control, muscle flexibility and new motor control, so on and so forth. So because we want to look into the hamstring injuries in sprinter athletics, and for that, today I only sort of present to you about the studies on the track and field athletes. Okay, now these are the studies that has been reported. These have been reported. Well, I do a recent search again. So basically, there are 2 more, but that is not. They are not RCT studies. They are only prospective studies. I will show that to you later on as well. Okay, there are basically 4 studies in here. The earliest one is 1972, and then the latest one is the studies by us. So basically, if you can look into here, is they also illustrate to you the change in the way that you assess the muscle strength. In the early studies, like 72, early 80s, you don't have the isokinetic machine. You don't have the isokinetic machines. The only way that you assess the muscle strength is isometric testing, isn't it? Using your tensiometers. So at that time, they're using the isometric testing, the one by Christensen and Weissman, probably the first one who looked into the sort of the muscle imbalance between the hamstring and the quadriceps. So they predict 5 athletes who have the injury. Eventually, it's only 2. So that's a 22%. And basically, the prevalence of injuries are around 20 plus to 40%. So Yamamoto's and Sokia, they are Japanese group, and they are group. I'll show that to you on all these studies later on. Have a look on this first. So this is the one. That's one by Christensen. 9 track and field athletes, include sprinter, hurdlers, and non-jumpers. They did isometric testing at 120, 150 degree Lee fashion. What they did is they predict 5 injuries, eventually 2 suffer from injuries. So what they say is with the 10% differences between the sort of the left, the quad and hamstring, that could be the injuries. But eventually they only predict 2 out of the 5 they predict injuries, but throughout the seasons they only found 2 injuries. So that's the one. Of course, scientifically, there's a lot of pitfall on the studies. That's the one by Yamamoto, using the tensiometers, isometric testing at different range of the hip, Lee factor, hip factor, Lee factors, Lee extensor, hip extensor, and so on and so forth. So for that, they noticed that if there's a differences weakness of the Lee flexions, the strain group versus the non-strain group, there's a significant difference in terms of the strength of a Lee flexion. That means the hamstring. And on top, there are also differences in the HQ ratio. Now is the first time we talk about HQ ratio. They mean the hamstring and the quad. Non-strain, you have half, more than half on that. They're less than half for the hamstring, and that's why you talk about 60%. You have to be 60% between the quad and the hamstring. There's a traditional wisdom that we talk about this. So this is the one by Sakayua. Using the isokinetic machine. This is the one who's using isokinetic machines. Very strange. They mimic the sort of using a sprinting actions. So they using the isokinetic machines, but it's not in the sitting position. In the standing position, testing the hip flexion and extension. Very interesting sort of setup. So what they notice is by doing the isokinetic testing at 60 degrees per second, they notice that for the weakness of the injured leg with eccentric action of the hamstring muscles during concentric actions of the hip extensor, and then performing side-to-side compression for the injured sprinter. The hamstring injury always occur on the weaker side. And there are differences in the hamstring cord and hip extensor cord strength ratio between uninjured and injured leg. So that was the findings at 60 degrees. And this is the findings from us. A very long time. We will sort of we follow 44 sprinter throughout the whole session, whole seasons, and we assess the hamstring flexibility, concentric and eccentric, pit torque, and so on and so forth. So what we notice is 8 athletes sustained hamstring injuries out of the 44, about 20%. And the injury rate of 0.87 per 1,000 hours of exposure. And then we noticed that the incidence of injuries were higher at the beginning of the season, with 58% injuries occur in the first 100 hours of exposure. That means, I still have 15 minutes. I was thinking I want to stop. That means I have to slow down a little bit. I have 15 minutes, so I can slow down a little bit. Okay, so beginning of the season, first 100 hours of exposure. That's very important. Transition in the pre-season to the season training for the coaches. That could be the take-home message. If you get your athletes to get into the sprint session very early, then we have a chance to get injuries. That's something you want to notice in here. And when we're doing some kind of a cost regression analysis, we revealed that the cockpit, the hamstring and quadricep pit torque ratio was less than 0.6 at angular velocity 180s, have a 70 times more having the hamstring injury risk. That's the finding. If you ask me, because we do a lot of, we do a different velocity, we analyze the pit torque, we analyze a different range, especially end range, but that's a statistic showing us that 180 degrees with less than 2/3 ratio, with higher chance will have 7 times more injury. So if you buy this idea, certainly, as a coach or whatever, you have to making sure that it's a balance between the left and right, a good balance between the cord and hamstring, a good balance between the concentric and eccentric of your cord, isn't it, at high speed. I think that could be at least the bring-home message in terms of muscles injuries, in terms of the muscle imbalance in here. So these are the sort of summary, bit busy. So basically telling you that muscle imbalance could be a possible contributing factors. But how imbalanced then you use your sort of your wisdom, looking, as I said, whether it's a purely concentric, eccentric. If you ask me, I still buy it's a concentric, eccentric issues. Concentric versus eccentric. But it's at what speed, at what range. I don't think it's a pit torque. There should be at particular range, particular speed. Having said that, it all depends. I think for sprinter, that is wisely to stay like this. But a footballer, rugby player, there could be difference. Because the injuries will be like this, for sprinter, they are at maximum speed that normally have the injury. But for rugby player, footballer, normally they are not at the high speed when they're injured. And there are other types of hamstring injury as well that I haven't talked about. It's a fully stretch. The dancers, you sort of forcefully stretch the hamstring and cause the injury. And that normally at the muscular tendon junction, at the ischial tuberosity. That's another type of injuries. But I don't think time will allow me to elaborate on this. Okay. let's talk about muscles, then we go ahead for the flexibility. I think because we all very fancy about flexibility, isn't it? You always ask your patients to stretch. I think I'm the one who won't advocate stretching. I think I have some contribution, if you ask me. I have some contribution in the scientific, in the running community. I have been running my marathon clinic for, I think, since 2008, many years. I can't say I'm the one who stirred up all the running group that bring into lots of business for the running groups now. I'm the one who not doing the static stretch. We never do static stretch. I don't believe in this. And our Cochrane review so very, very strong that static stretch is no use before the training session, no use. At least for running, at least for long distance running. Even for sprinter, I don't think static stretch make any sense in terms of preparation. And now this day we all do, I think you see many, aside from our marathon clinic, many running groups, they advocate dynamic stretch now, dynamic drills. Static stretch doesn't make any sense. I don't think that biomechanics or whatever, basically it's not work. But post-training, static stretch will make sense. Of course, that if you want to learn more, you come back next Saturday. Next Saturday afternoon, there's another seminar by Hong Kong AAA, not by SF&OC. There's another seminar on marathon seminars. I will talk about some sort of musculoskeletal injuries and how we can prevent on that. I'm still preparing on this. So flexibility, here. Basically, a lot of studies, blah, 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 blah. If you are familiar with the meta-analysis, you look into the CI, very important. If car passes one, no use. And the p-value, 0.75, basically telling you flexibility won't make any sense in terms of prevention, at least from all these RCT, randomized control trial studies. In fact, this is what we have been doing. We're doing effects of a 4-week static hamstring stretching exercise in the alleviation of stretch-induced muscle damage. Yes, and that's we're using this gadget to look into the sort of the viscoelastic properties of the tensile stretch. What we noticed, there are no significant change of the passive stiffness after the 4 weeks of static stretching. So stretching does not appear to have any protective effect against eccentric muscle damage. So this is one of our earliest studies by our MSc students. So that's a prevention. I haven't talked about the neuromuscular control, blah, 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 blah. Basically, it's our wishful thinking. But in fact, the studies by Sukuyawa, they try to say that that can help. But, well, if you want, I can talk to you later on to this. OK, let's go on to prevention. Otherwise, I will see the 5 minutes signage for me very soon. OK, prevention. We all know. If muscle strength is so important, and then the eccentric strength is so important, eccentric training is good, isn't it? And that's why you all learn about the Lordic hamstring exercise. Any one of you have tried the Lordic hamstring exercise? So only one. Oh, OK. So you are two. You have tried this out. It's reasonably challenging, isn't it? It's reasonably challenging. And depends how good you can perform. Of course, we can do it in a correct manner. At the beginning, we may pop up with the pillows or whatever to do the small art first. So these are the studies indicated to you that the Lordic hamstring exercise is effective in the prevention of hamstring injury, in particular for certain sports. But having said that, the compliances for the Lordic eccentric training is not that high, the compliances. Some team has been successful is they incorporate the Lordic exercise in the warm-up program. That seems to be most effective. So these are the eccentric exercise. And why that can help? We have a study looking into this. The effect of concentric and eccentric hamstring training against stretch-induced muscle damage. So we compare why eccentric better concentric. So doing this, we noticed that by eccentric training, there is a significant shift in the pit-top angle to a longer muscle length. If you believe in the popping sarcomere theory, then you will certainly think that if you can shift your optimum length into the long end range, that you may have the protection. So by doing that, well, we think that is the protective effects of the eccentric training is due to the shift of the pit-top angle. That's our contention. Okay, for eccentric lordotic is good. How about specifically for hamstring then? For hamstring, so my friend Mediopolis have a hamstring exercise for track and field athletes for injury prevention. So reasonably good studies. I'm not saying very good, but at least there are some pictures some for you to borrow. Oh, 5 minutes. I will accelerate my talk again. So this one exercise, very important. Basically, you hold it doing the core, stretching this, and doing your hamstring. This is one exercise. The first one, single leg deadlift. So you can increase the resistance by putting more weight in here. So that's the one. This is a CKC exercise, isn't it? This is CKC. This is the other one. Different angle, pelvic tilt lifting. CKC, strengthening of the co-contraction of the hamstring and your hip extensor. And this is the OKC. It's very good, concentric and eccentric at end range. So hamstring catapult, that's another exercise. And this is mimic the running condition, sprinter, eccentric leg curl. Keep the leg straight. Concentric and eccentric again. So this is a good exercise. I personally think good exercise for the sprinter. And then, of course, you can add onto the core training. There are different versions of the core training. You can certainly consult Dr. YouTube onto this. So that's the prevention. That means prevention, in terms of prevention, you can use this exercise to your sprinter or your athletes. Try whether that is work. Rehabilitation, how about when you suffer from hamstring injuries? Okay, this is the one that you learn about the Asken protocol. The Asken. If you haven't learned about Asken protocol, congratulations that you are not good enough to treat any hamstring injuries. My friend Asken have a good some good studies looking into the particular protocol in the treatment of rehabilitation of the hamstring injury. Basically, 3 basic exercises. It's a lengthening exercise. So this is the first one. The first one, what we call the extender. So you start sort of a hold and stabilize the fly and doing this exercise just before there's pain. So in fact, you can start very early on doing this. Have a look onto this. Execution is important. Start at the end range of pain. So you can start very, very early. Execution. I like the reason why I like Asken is things look very simple, but the execution is very, very, very exact. Very, very exact. Keep sort of what you want to do. This is the first exercise. Okay, the next one is what we call a diver. Another good exercise. Gradually increase. Have a look onto this. So, go to the point of pain. Of course, we are stretching onto the hamstring of this. Keep this 90 degree. This straight and gradually increase. I see too many people doing this, but it's not in the correct manner. 90 degree. Keep straight. Keep straight, holding your core and gradually stretch. Bend a bit of your knee in here. This is a diver. And then the last one is the slider. The glider. Look at this. Gradually glide. You're stretching onto the hamstring. Stretching onto this. Gradually. Of course, this should be frictionless as possible. And doing this. Gradually increase to the limit of pain. This is what he called the L protocol. And then if you compare to the traditional protocol, that means you stretch, static stretch. And your strengthening exercise, your traditional one, if you compare this and your sort of pelvic tilt, and then you compare the two programs, what they notice is the lengthening protocol, the L protocol, the times to return to sports is 28 days for footballers, sprinter, 49 days versus using a traditional program. That means your static stretch, your concentric strength exercise, you take a longer time. And then re-injury rate, new. There's a re-injury for your classical or your typical exercise program. Okay, the last slide, return to sports. Return to sports, there are sort of criteria. The different criteria, so palpable tenderness, power, return to normal, so on and so forth. This is the one I like, the Askin, the H test. Basically, you strap onto this, strap nicely, and ask the patient to lift up the leg as quick as possible. If there's no apprehension onto this, there's a good sign that the muscle have been returning reasonably good. So that's the return to sports criteria under this. I think I better stop in here. There's some more slides, but I don't think that make any differences because timing is very important, isn't it? If you want, then maybe you come back to Poly. If they still invite me to give the lectures, then you may learn more from me. But my general understanding, my student like Professor Google rather than me very much. And that's why they always fail in the practical test. Okay, questions you want to ask? But I have no answer for sure. Okay, yes.
好，咁啦，多謝晒楊博士嘅分享啦。咁啦，楊博士咧就引用咗一啲肌肉創傷嘅理論啦，落去一啲真實嘅案例，相信大家都了解多咗嘅。咁啦，我手頭上都有幾條問題啦。咁咧喺 slide 上面咧都收到大家嘅問題啦。咁啦，阿 Felix 咧就想問一問楊博士啦。Some trainers suggest that hamstring injury is due to weak hip mobility. Does athlete may overstretch their muscles? Do you think this may be one of the reasons?
Hip mobility, and the hip is not good enough. That means which plane? You know, hip, ball, and socket joint. Sagittal plane, transverse planes, coronal plane, or combination. Hip related to the pelvic? I really don't know. I don't know. You think there's a limitation, a very substantial limitation of the hip movement, and certainly you may try onto this. My bet will be more onto the core rather than onto the hip. But you can. But I don't know. Because, I don't know basically means I haven't read articles onto this, as I said. If there's significance of limitation in the hip, then you certainly may try to mobilize the hip joints. But for sprinter, normally very young age, I reasonably doubt that could be the hip problems. That could be the, I don't know, but that might be the impingement that causes the problem, but I don't know. I don't know. I better ask Professor Google.
好，唔該晒 Simon。咁呢度有另一條問題。
Oh no, I'm just trying to follow up that because that's the question I asked. Because probably usually like some American researchers or trainers, they suggest that probably when we consider the frontal plane, some athletes, when they try to move their
sagittal
muscles.
Plane? Sagittal. Frontal plane.
Oh, sagittal plane.
Oh, sagittal plane. Flexion extension.
So sorry, yeah.
Make it more. Flexion extension. Yes.
Yeah, they find that sometimes these athletes, they want to like have more strike length. However, because they have weak hip mobility, they try to stretch more. They try to overstretch their muscles so that they can probably produce more strike lengths. But then they starting to produce more force on the hamstring. That is why it caused a lot of massive injury. So I would like to ask if probably that is one of the concerns which we should focus
hip mobility?
more.
What hip mobility you require for a sprinter? What hip mobility you require for a sprinter?
For example, like
how much you need?
For example, like the pelvis, like sometimes when we want
you talking about pelvis or hip now?
Both, like sometimes the iliopsoas
well.
muscles, for example, the iliopsoas muscles, or sometimes when we want to like produce more force in our gluteus maximus.
I think different issue. Don't mix up the issue. We talk about a hip mobility or muscle weakness. Because talk about iliopsoas, hip extensor, that related to muscle weakness. You talk about a hip mobility. Is this the joint limitation. I don't know, because I really don't know about, I don't exactly sort of capture your questions. But if you ask me if the hip mobility, then the next question I will ask during the swing phase, how much hip movement, this is the hip movement that you require, isn't it? Then we talk about the muscles problem, then we can certainly look into this. That could be. I don't know. Interesting, I don't know. But of course, you can test this out yourself. The stride, if you stride, it's overstride this one. Overstride this is not related to here. If you overstride, it's only this, you overstride. And that's why we always ask is, you push off, you lift up, you stride, but before you land, you should have this action rather than this. If you stride like this, you land like this. In fact, when you run, you go like this. When you land, before you land, you have this action. You should have this action. Then you can roll forward. I don't know. I really don't know. Yes, thank you for your question. Thank you very much. And
thank you for the answer. So ask one more question.
Yes.
For elite athlete hamstring injury, is it the physio job to progress back to high velocity or the trainers? This is the question.
High velocity?
High velocity or high loading leap training or the trainers?
Yes. But yes, you mean high velocity strengthening exercise?
Yep.
Yeah. Yes. Of course. But I will bet on the eccentric more. Yeah, of course. Yes. I think yes.
Okay. So I hope the answer can answer the participants'
yes.
questions. So let's move on to the presentation of certificate section. So please, Fallon.
Oh, okay, thank you.
Okay.
Thank you so much.
Thank you very much.好多謝晒兩位，好俾多次掌聲俾 Simon 係啦，分享咗好多有關於 muscle injury 嘅知識俾我哋嘅。